I suppose that starts off with when you're examining the legs, do make sure that you get good exposure of the legs. You do need to be able to see what's happening in the quadriceps and a decent exposure. I suppose that Dr. Saifuddin is very exacting in neurology and gives you all the small elements and has a huge knowledge of it. I have a slightly different approach which is really thinking about the exam. So, first of all, if we think of examining the legs, that is 50% of the cases that are used in neurology in PACES around the world. So it's the most likely thing you're going to have to do when you actually sit the PACES exam. The percentages are roughly 50% is something to do with the legs, and then it's about 30% upper limbs and about 20% cranial nerves. So that's just your odds as you walk in. But as you walk in, you just have to take whatever patient you're given. So, but it's good to actually be good at legs, because it's the most likely one you're going to come up with. And as I said to you, the stem will always tell you where to start. Now, it will usually say the patient has difficulty walking or is unable to walk. Clearly, if it's unable to walk, that means we're telling you you can't get the patient up to walk, and in fact, asking them if they would get up and walk if they're unable to walk is pretty unkind and will not be a good start. So unable to walk, that's it. You examine the legs. If it's difficulty walking, you have the opportunity, if you want to take it up, of getting the patient to walk. Now, this has been a cause on this course over the years of a little bit of, I suppose, different examiners saying different things about this. And what I would say is there's no right or wrong. Some examiners think if it's difficulty walking, if it's difficulty walking, then get them up straight away. That's some people's stance. Take a quick minute and actually assess gait, and you can do Rombergs, you can do your tandem walk, depending on what you're seeing. Others say only do that if you've got time at the end. Now, there's not a right or wrong. I'm a get them up and walk at the beginning man, but there are plenty of others who think the other way. But think about when you're actually examining the legs and it's a difficulty walking, are you going to get on and actually examine the gait? So clearly I'm not going to get this gentleman to get up and walk because we know he's a healthy volunteer, so there's not much point. He's just managed to demonstrate that he can walk across the room, climb a step and get onto the couch without falling over. The things that you gain by asking people to actually walk very quickly is that you can quite often spot what the problem is just from the gait, and that will allow you to focus everything after that. So if somebody's dragging one leg, you know that there's almost bound to be a weakness in that leg. If they're high stepping, you know that you've got a sensory issue almost certainly. If they're shuffling, and I'd have to say in neurology we sometimes cheat and we'll use muscle disease as well as neurology. So if you get somebody who's waddling like this, they've probably got a muscular dystrophy, and you'll tell that the minute they start walking, in which case you're going to pick up muscle weakness but no neurology. So the gait can tell you a lot about what's going on. And obviously a ataxic gait, which I saw Saifuddin was talking about. And while you get the person, get them to go up a few steps, get them to turn round. If they're clearly unsteady on their feet, you can do the Rombergs before you get them back on the couch, and you've picked up a lot of information. Okay? I would tell you, don't let the patient fall over, because if you let the patient fall over and hurt themselves, you've failed the exam. The important thing, not to actually hurt the patient. Now, I suppose the next thing to think about is you've got 6 minutes. I've already used probably the first minute introducing myself and getting the patient to walk. So you have 5 minutes left. And at that point, the examiners are going to stop you examining. Now, what do you need to achieve in 5 minutes? You need to think about inspection. You then got to think of tone, power, reflexes, lateral sensory change, dorsal change, coordination. 7 things in 5 minutes. Okay? Now, if you start thinking about your timings, if you then do a check of every muscle group for motor power, you'll have used, I would have said, a minimum of 3 minutes to do that. Therefore, you're not going to be doing something else. Now, if there's a motor problem, that might be good. But if the problem is sensory, and you haven't got to the sensory elements and you miss them out, things are going to go very badly. So what I'm going to try and go over in neurology is what I would do in a 6-minute routine. And what I would suggest you do is that for each of the modalities that you're looking for, that you're actually thinking about a screening test. Is there a major problem in this area? If so, you spend more time on it. If your screening test is clear, you go on to the next thing you need to do. So we'll talk about that. So I'm not teaching you how to do the perfect neurological examination of the leg, because you can't do it in 6 minutes. Maybe a consultant neurologist might, but we are assessing you as a general physician doing an examination of the legs in a specific time. So, can you lie back on the couch? Just lying flat. Yeah, thank you. Okay, that's fine. So you want to have the patient clearly relaxed. Some people do like them hanging over the side of the bed. For me, much easier just having them either lying or sitting in the bed with a reasonable exposure. Oops, trying to trip myself up here. Maybe I'm proving I've got a problem. So you need to be able to see the quadriceps. So thinking that you've got 6 minutes if you haven't walked the patient, or 5 minutes if you have walked the patient. Quick examination of the legs. So you're looking clearly for muscle wasting. You may do a couple of flicks for fasciculation, looking for obvious atrophy. This should only take a matter of 10 or 20 seconds, because that's all the time you really have for it. You're then wanting to check tone, just very quickly checking tone, and you may just want to do a little bit of movement to see where you are. If you think the tone is up, then bend your leg, and do clonus. Number of times I see people checking clonus on a straight leg. You can't actually get clonus on this. You need to actually have the knee bent to be able to get to elicit the clonus, and you're wanting to sharply up and then relax your hand and see what happens. So we're checking tone. Clearly it's all normal in this case. So that's, say, inspection, tone, 30, 45 seconds.
Can we check the tonus at this point itself,
Yes.
or after the reflex?
It doesn't matter to me. If you've got, your job is to persuade me as an examiner that you know what you're doing and that you've elicited signs. So for me, if you're moving patients around and that I think somebody's got increased tone, then if I check for clonus at that point and I get clonus, I know instantly that I'm dealing with upper motor neuron problem. So you could do it after you've found that the reflex is that they've got hyperreflexia. You can do it then as well. I don't care when you do it. I just find for my examination when I'm doing it, I tend to see if I pick up the tone then, I'll tend to do the clonus. If I don't pick up increased tone, but then I think the reflexes are much brisker than they should be, I might do it then. Okay? So we're doing that, then we're checking power. Now, I do see quite regularly people checking hip, knee, ankle, and toe power. extension and flexion, that will take you a long time, which you don't have. So I would suggest that for the purposes of exam technique, what you need to know are, is there proximal weakness, is there distal weakness, and is it unilateral or is it bilateral? Because that's generally what I want. So this is, as I said, a screening test. So can you lift this leg straight off the bed? Hold it there, don't let me push it down. Good. Come down, push your leg down hard into the bed. Good. And I would do the same on the other side. Proximal power feels very good. Then push your foot down, don't let me push it up. Again, push down, don't let me push up. Okay, pull your foot up and pull your foot up. Okay, so it's equal, strong, proximally and distally. And that's all I would do for power. If, however, I found power was good here, very weak here, then I'm going to have to work out where in between it goes weak. So think about screening test. If there's an abnormality, spend more time on that. If it's normal, go on to the next thing. So we're then thinking about reflexes. Do handle this as if you've looked at it before and that you've used it before. Surprising how many people are, I mean, it's meant to be a delicate pendular movement, so try and look like you know what you're doing. Then bend your legs, just relax. Getting patients to relax, as you know, can be difficult. Now the next thing is that this is meant to hit the tendon. The number of times I see this hitting the tibial tuberosity, the patella, all sorts. I think there's some people who, when they use this, think that they just vaguely need this to contact somewhere around the knee. We're actually looking for it to hit the tendon and actually do something. And he's not relaxed. Try and relax as much as you can. I know it's really easy. Just think that they aren't there. Now, it remains tense, but what we're aiming here is for the tibia, and at the moment I can't get any obvious reflex, which I'm sure he has. If you get a situation where you're having difficulty, don't tell anyone that they've got absent reflexes unless you've ensured that with reinforcement. So can you just take hold of your hands and go like this? And when I tell you, I'm going to want you to just try and pull your hands apart, but resist. So pulling as hard as you can like that, just when you're free. So try and relax. This man is not for relaxing. Yeah. You do yoga? Okay, pull hard, please. Okay, and there is a small jerk there. Thank you very much. Relax. So do be aware that patients don't relax necessarily, so sometimes reflexes are difficult, but don't say that you've got absent jerks if you haven't checked for reinforcement. Then we go on to ankle clearly. Can you just let your leg flop out like that? And again, just relax. Relax. If you relax, your foot isn't solid like this. Okay. Just try and relax. Okay. And again, don't hit the heel. Don't go away up here. Don't end up hitting somewhere on the gastrocnemius muscle. We're wanting it actually on the Achilles tendon. And again, just a drop. And there is a small jerk there. Again, common, easy one there. You relaxed. Well done. Easy one that I see, I quite often see this. You can't get an ankle jerk if your leg's straight. So remember that you've got to position the legs properly. So bent legs for clonus and for ankle jerks. We then come to Babinski. That's obviously a point at which you could hurt the patient. So be careful. I get some people who quickly whip out some lethal looking weapon from their lapel and stab it into the person's foot, who then jumps off the bed because they don't know what's about to happen, and that's not going to go very well for you, okay? So I usually would warn the patient, this may be a bit uncomfortable, and use something that is not too unpleasant. We don't allow people to use needles, for example. There's a thing called Neurotips that you'll find in the exam, which is a little plastic gizmo with a blunt bit of plastic at one end and basically a thin metal rod on the other end that is not a needle and therefore can't break the skin. Okay, that's okay. I hope that this one will work. And what I'm going to do, so this may be a bit uncomfortable, and round the outside of the foot. And that's clearly down. And that's clearly down. You don't need to inflict pain to get a Babinski. So you shouldn't be doing that. And start off soft, and if you don't get a response, be a bit firmer. I mean, we all know that sometimes people just have a marked withdrawal response, or they've got tickly feet. It's sometimes difficult. But, you know, it's clearly important that we see you do the Babinski. So around this side of things, so the jerks, if you need reinforcement, will take a little while. If they're brisk, then it's much easier. And if I'm not sure about being brisk, particularly at the knee, what I tend to do is I just tap them with my fingers. And as far as I'm concerned, if I can tap and elicit a reflex just with a finger tap, as if you're percussing, then by definition you've got hyperreflexia. Shouldn't really be able to do that. So I'd already said that I've taken maybe 45 seconds for the tone and inspection. Muscle power, if we're just looking at the screening test, we've taken probably a minute over that. And now our reflexes have taken a minute already. So we're out at about 4 minutes with 2 minutes left. Okay? And if you've picked up other things, then you will have to spend a bit more time. So we then are on to effectively sensation. And there are 4 different sensory modalities. You've got 2 minutes, and you're also going to have to check coordination. You don't have time to do all of the sensory checks. So for me, I tend to think of, as a screening test, doing one of the lateral column, one of the dorsal column. So light touch or pinprick to check the dorsal column. So since I don't want to be stabbing a volunteer, we'll use light touch. Always start at the top. So you're just going to feel this as a light touch. Okay, you feel that? Okay. So, and then just light touch again. What I'm interested in is sensation normal here compared to the forehead. So does this feel the same? Same. Okay. What about down here? Same? Don't tell me there's anything wrong. I'm not here to make a diagnosis. Okay. What about here? You feel it? Less? Does it feel less? No, it feels the same. So this, I could use pinprick or light touch. I'm checking the lateral column, and again, the important thing is the sensation from here to the area where I'm starting testing the same, and then is it normal at the bottom? One of the commonest things that turns up in the exam is diabetic peripheral neuropathy, in which case you should have normal sensation up at the top, but you're going to have altered sensation down here. And it may just be a sensory neuropathy, or there may also be sensory motor change. So you may have picked up a problem motor-wise. Now, quite often I get people who actually, it's abnormal here and here, and they say that, they just tell me they've got a sensory neuropathy. Now, if they're abnormal here and they're normal here, you have to work out where does it become normal. So although we're saying that you want to examine the legs, find out where the sensory level is, because the sensory level will tell you a lot to help you with your differential diagnosis. So if I find that sensation isn't normal at the top of the leg, then I'm going to have to expose the patient further and actually find out where the sensory level is. If you don't do that, it suggests to me that you're just not thinking. Now, there are differences in what fibers carry light touch from pinprick, but I just don't think in the exam timing that there's enough time. So I would suggest you do one or the other. That's already taken another 30-35 seconds. So we're then going to use the dorsal column. Now, you can obviously use the tuning fork. I tend to think that that takes a lot longer than proprioception, and you're tight for time. There's no doubt that the tuning fork and vibration sense is the one you lose first, but it's also the one that, the number of times I see somebody in 20 seconds sort of jamming a tuning fork onto the side of somebody's foot and say, do you feel that? And then saying, you know, vibration sense intact. Well, all they're feeling is the tuning fork. They're, you know, are they aware of the vibration? Can they tell you when the vibration actually stops? And the other thing that classically we see it's amazing the number of places you can put a tuning fork. You know, that it's the middle of the toe, somewhere halfway up the foot, in the middle of the foot. It has to be on a bony prominence. So if you're going to use a tuning fork, which is fine, if you want to, I don't have a problem with that, but make sure it goes on a bony prominence, and it will take you longer than proprioception. So for me, proprioception is my test of dorsal column. The next bit is you do not actually give the patient sensory information by holding the foot or the toe at the front and the back, because then you're giving people sensory information so they know which way it's going. You have to hold the toes, the foot laterally and the toe laterally, then up and down, eyes closed for the patient, then get them to tell which way that's going and which way this is going. Again, if you have vibration, if you have proprioceptive problems here, you may need to go higher, but just being able to spot that is usually fine. And then coordination. Can you please put your heel, keep this leg straight, please. This leg straight, this leg straight. Yeah, just straight out. Okay, thank you. And this one, put on your heel and run it very slowly down the bone. Just slowly. Okay, thank you. I'm not going to do both sides because we know it's going to be normal. So really that's the quick test for coordination. Do be aware that if you're weak, that if you've detected muscle weakness, that coordination isn't going to look very clever. So you need to try and make sure if you've got paresis, that if they're not very good at the heel shin test, is that a cerebellar problem or is it just down to the weakness? If you're not sure, you could always look for nystagmus or do a finger-nose test, because if it's a cerebellar problem, there's going to be other places to look for cerebellar issues. And that's one of the other things we talk about at the end of this. You know, to do all of this in 6 minutes is quite hard work. And that's really what I'm trying to do, is cone it down to the minimum you need to do to get through all the modalities in the 6 minutes. If people are very slick, they do finish early. So, you know, if you have weakness down in one leg against the other, what's the arm doing? Is there any paresis here? If you get coordination problems here, then check for dysdiadochokinesis, look for nystagmus. In your last 30 seconds that you might have left, look for confirmatory issues that this is a cerebellar problem. Look, if you think somebody from their gait is Parkinsonian, then again you might want dysdiadochokinesis. You might actually want to do finger-nose tests again to look for intention tremor. So things that you can do in the last 30 seconds or so to just try and confirm your diagnosis. As I said, if you have a sensory problem that goes all the way up, you have to find out where the sensory level is. because that greatly influences the differential diagnosis. Okay, so I suspect I was shorter than Dr. Saifuddin because it's a slightly different approach to neurology. I'm a pragmatist. So are there questions or queries that you want to ask? Yep.
So when you're testing for soft touch, that time you just use a wad of cotton, or do you make it into a sharp tip and use?
I don't think it, I mean, I think it needs to be a relatively sharp point, because otherwise it's a very diffuse sensory effect you're giving. You're wanting, can they touch? So, but I don't really, I mean, if you just dabbed a cotton wool, that would be unusual. I don't see that very often. Most people will make it into some sort of point. So I think that would be best.
Sir, if at all we need to test to all the muscles, if you find any weakness, so what are the muscles are we expected to look for
I
in
think,
the lower
I mean,
limbs?
if you've worked out that power is, I mean, if power is globally weak,
Yes.
then I suppose what you're wanting, if you think that it's weak distally and proximally, it's very unlikely that there's going to be normal power in between.
So,
it's then,
yes.
you know, is there a power loss higher up? So is there a power loss in the upper limbs? Can you try and, the commonest one for that, well, I suppose it could be a spastic paraparesis, because they come up quite often in the exam, but you'll pick that up from the increased tone when you examine them. You'll probably have clonus by that time, so that will be fairly obvious. If it's muscle weakness, the muscular dystrophies, it tends to be proximal, but then you've got better preserved distal power, whereas pyramidal weakness is classically weaker distally, so that, you know, the pattern of the weakness is going to help you, and I mean, I think if it's weak higher up, I tend to think that the commonest reason, there are things like diabetic amyotrophy and things, but in general, think muscle disease, proximal myopathies, and potential explanations for that.
So my question is, if we demonstrate a weakness in our screening technique, then are we expected to go back and demonstrate which muscles are weak specifically?
I think if you find that the power is normal proximally, but it's weak distally, then we'll want you to demonstrate what the power, where the power is lost.
Okay.
So at that point, So at that point, I think we would be expecting you to at least check flexion extension at the knee as a halfway point. Okay.
So ventral loss of sensations would be tested with eyes open or eyes closed?
Eyes closed, I suppose, if you're checking sensation is the way we're meant to do it. I think in general patients are honest. But certainly for proprioception, I always get them to close their eyes. Light touch, I have to admit, I sometimes ask them just to tell me if they can feel it. But if you're doing it properly, then I think it is the way that you're meant to say yes, yes, each time they feel you touching. I tend to find that patients aren't very good at following that command. So, you know, you'll touch them in about 5 places and then you'll get a yes, and you don't know which place it was they felt you. If they're looking at it, I think sometimes you get a more reliable answer. But this is not, as I said, I am not giving you the gospel that has to be followed. This, you know, that this is what I'm looking for. We have 2,000 examiners, and all of us